One of the things that is interesting, and when we hear about the clinics, like obviously the Prof's clinic in Beaumont is the one that most of you will be familiar with, but obviously we've got Dr. Ryan's clinic in the CUH, and we have the clinic in UCHG as well. And working together as a team really benefits patients, and that's where we come in, and we have to integrate with those teams as well, so that we aren't doing something out of kilter with the team that's there. And that's where it becomes important that we so communicate well together. And what we want is people to live well with this condition. Their questions are answered in a timely fashion. They get the right treatment when they need it, and having a real sense of team is important. So to talk about that, will you please welcome the Advanced Nurse Practitioner from University College Hospital Galway, Teresa Leahy, ladies and gentlemen.
Hello, it's nice. Thanks for asking me to present today. My name's Teresa, and I work in University Hospital Galway. And I see some familiar faces out there today, which is nice to see. So I was asked today to present our clinic in Galway. The slides have moved a little bit, but so. Going backwards. Oh, here we go.
Yeah, green forward, red back. Yeah.
Lovely, thank you. I just said briefly, what is MND? So it's a progressive neurodegenerative disorder that attacks both the upper and lower motor neurons, or nerves, as Professor Hardiman spoke about earlier. And this leads to spasticity or stiffness, and increased reflexes, which is your upper motor signs, and weakness and wasting of the muscles, which is your lower motor nerves. And who gets MND? The average age is 40 to 70. However, there is some exceptions. And indeed, we've had patients in their 20s and 30s that have developed this condition. Men more than women in most cases and types. Possible links with environmental factors. And there's definite genetic links. And the lifetime risk is 1 in 400, with about 80 to 100 cases per year. And up to 400 people with motor neuron disease in Ireland at any one time. So they're the different types of motor neuron disease which was spoken about earlier. And it is thought that the mean time to diagnosis is about 11 months, and that can be very unsettling for patients and their families as they navigate their way through the health service, waiting to find out what's wrong and find a diagnosis. So diagnosis is usually one of exclusion. So we want to make sure, you have a confirmed diagnosis. So often there might be imaging, the brain and MRI imaging to see if there's any problems there. It has to be diagnosed by a neurologist. It's usually diagnosed in a clinical assessment with supportive diagnostics, which is gold standard is the EMG, but often the clinical diagnosis is the most important. We offer our patients referral to Professor Hardiman in Beaumont for a second opinion, and also for any eligibility of any pending clinical trials. So just a small overview of our clinic. I commenced my post in 2004, and my primary remit was caring for patients with multiple sclerosis and epilepsy. But during my time there, I came across patients that were being diagnosed with motor neuron disease, and I just wondered what happened when they were discharged, and that there was a great need for support once they got discharged into the community. So with that in mind, I approached our consultants and MDT team to see if they thought it would be a good idea to set up a specialist clinic, and thankfully they all supported me, which was very good because they had a lot of clinics already. So in January 2011, we set up our first MDT clinic. And initially it was once a month, but the numbers grew, and we now run it twice monthly. And even with that, the numbers is getting quite full. Patients attend every 3 months because that's a good time frame to see how people's condition is going. And we have some patients, though, that will come to us 6 monthly. It's a small group, but that there are people that may have, their MND may be stable. However, that's with the proviso that if there's any problems, they can contact me via the telephone service and we can change as needed. We have a palliative care consultant that attends our clinics once a month. We had a respiratory consultant who used to attend our clinics once a month. However, he's retired, but there's a new respiratory consultant who is looking after our patient cohort and always responds and sees our patients very promptly. At our clinic, we have Fiona, our speech and language therapist, Mary, our physio, Sarah, our OT, a registrar attends with me majority of the times, and Fidelma, our MND nurse, will whenever she can. Unfortunately, we had dietetics, but they keep pulling the service due to cutbacks. So at the moment, we have no social worker, but I'm negotiating to see if we can have somebody attend our clinic. So the goal of our clinic is to support the person with MND and their family throughout their disease continuum, to preempt symptoms with early intervention and manage those symptoms, and promote the best quality of life for people, for that person and their family. So, sorry now, just turning back and forth. So it's about collaboration, and there's a lot of different specialities, and I try to mobilize as many specialities as I can. The idea is to utilize their expertise and to get as much support for the person in both the acute sector and the community sector. So I draw all expertise in. So we have our neurology team who liaise with their counterparts in the community, respiratory team, which I spoke about. I've linked in with the radiologists and the intervention team, and they're in charge of our radiologically inserted gastrostomy tubes. Again, linked very closely with the IMNDA, and Fidelma, our community nurse, she's my eyes and ears in the community, and mine in the acute sector, so we link very closely. So if there's any problems, we'll work very closely together. And again, the IMNDA, there's a lot of support with equipment and things like that, and grants. Palliative care team, we get heavily involved early, as Dr. Hardiman said, Professor Hardiman said. There's a lot of pre-existing ideas about palliative care. People are quite scared because they think of end of life or cancer, but they're really, really good with proactive symptom management. So we draw a lot on that. And again, we like to refer early to the home care palliative team, because the idea is that you build up a rapport with the person, and they're another layer of support and expertise in the community, and they can really help with symptom management like constipation, pain, and things like that. And I also linked with the radiation oncologist when we started this clinic, because there was a gold standard of radiation of parotids to help manage medically refractory saliva. Now, we don't actually do Botox or administer Botox in UCHG. However, the radiation of the parotids can work quite effectively. So just looking at symptom management, as we all said, early recognition is key. So we like to monitor for any clinical signs. We link in with our respiratory colleagues, and sometimes we might trial non-invasive ventilation for patients that may have fatigue. There may be no other symptoms and no other breathing problems, but occasionally it can benefit fatigue. Then the next thing we would look at is early recognition again of nutritional decline and weight loss. We know this condition increases your metabolism, I can never say that, metabolism, and we know that if you lose more than 10% of your weight, it's very hard to get that weight back. So I usually refer via the GP dietetics, keep an eye on things for supplements, and again, ongoing monitoring with Fiona, our speech and language therapist. Again, we try to discuss about early intervention of radiological inserted gastrostomies with the appropriate patient cohort. And we link with the Technopath support nurse, and she will now carry out home visits for pre-counselling, pre-rig counselling. And the idea is that patients can have a look at these tubes, look at the connections, and it just makes these tubes less abstract. It's more easier to understand than diagrams. Next would be saliva management. So again, we have our different treatments, but also palliative care have a lot of tricks of the trade. So again, we're looking at managing excess saliva and drooling, and again, if medically refractory, we'll refer to radiation oncology. Again, mobility, Mary, our physio, is very involved. We also may give Botox to some patients' lower limbs or upper limbs if they've got very severe spasticity. Again, the OT would have a lot of involvement just with adaptations, and again, we link in closely with the IMNDA for equipment, things like high-rise recliners and things like that. Emotional ability or pseudobulbar issues can be a very distressing symptom and is quite difficult to treat. We have some treatments, amitriptyline, SSRIs, that we have moderate benefit from. Again, some patients develop anxiety or breathlessness. We link in with our palliative care team to help with that symptom management. And sometimes, or not sometimes, but having this condition can be very difficult. So we would often advise or highlight that the IMND has a counselling service which can help patients as well to work through this difficult process. As we said before, cognition and thinking, we used to think they did not affect MND, but now we know that is different. That's not quite the case. So from that point of view, we know that although 50% of patients have not got any cognitive difficulties, there is 50% of patients that do with varying degrees. So that can have a devastating effect on decision, problem solving, behavioural changes, and again, for the family and the patient, that's one of the most difficult symptoms to manage, and it's where the highest caregiver burden. So again, it's to try and mobilise support from where we can to help support the patient and their family. There was a lady, I was looking at well-being, and there was a lady called Dagmar Munn who is living with ALS, and she talks about, she draws on her psychology experience, and she talks about the 4 M's, her formula for daily living. I thought it was quite nice. And the 4 M's was medication, mindfulness, emotion, and mood. And the idea was that medication, obviously to take the medication as prescribed, but she also talked about mindfulness and about being in the present and trying to mobilize that, and about how it helps her to navigate her condition. And she said when she starts drifting to future worries, she stops, takes a breath, gets back into the present and tries to manage her condition that way. Again, motion is talking about, sorry, I'm skipping through these because we're out of time. Motion's about really, I suppose, staying active and being active, and that it helps. Again, she talks about simple activities. So we always encourage people who like to enjoy gardening or the kind of things they enjoy to try and keep doing that it's important. And again, mood is really important for us all to keep an eye on mood, because it can be very difficult dealing with this condition, and if you have low mood, so we kind of monitor that. Again, signpost counselling services, and it's important to talk to your GP too if mood is down. So future planning and wishes, that can be quite a difficult topic, but it's important to introduce it early. And the Irish Hospice has a really nice booklet called Thinking Ahead, and the planning pack. And I think it's important because sometimes, if things happen suddenly, healthcare professionals roll around trying to fix things, and sometimes the person themselves gets missed. And it's all about your wishes and your decisions, and it's all about you. So it's important, if you can, to have a talk with your family and think about what you would like. So I suppose my role is to support the patient with motor neuron disease and their family throughout the continuum. I'd like to think that when a patient comes to our clinic, we'll say to them, you're not alone, we will go through this process with you. I have a telephone support service whereby people can ring in between times. So in other words, not to wait to your clinics. We can do a lot over the phone. And if people can't get hold of me, they'll ring Fidelma and she'll nab me. The idea would be preempting and sensitively introduce aids and appliances and different specialities, again, to do things in time to enhance your quality of life. Myself and Fiona are speech and language therapists. We carry out combined clinics. So if somebody has a modified barium swallow, we'll see them after the procedure and we'll just have a chat about the results and what our next plan may be. I'm a link between the hospital and community. I get a lot of phone calls from GPs and dietitians. And also I carry out an outreach clinic with Fidelma. She very kindly picks me up. I don't get out of the hospital as much as I'd like because of other conditions to mind as such. But when we do go out, it's brilliant. It's for the people that maybe are unable to come to our clinic, or if one of us are quite worried and we want to go out and see for ourselves. And I hope that I would be a patient's advocate. And again, it's all about the person. They have to be the centre of all decision making. We can advise as healthcare professionals, but it's your body and your decision. And I suppose just to say it's a team approach. Early referral and specialist input, prompt intervention, flexibility and frequent assessment. So somebody may ring me and say, I'm going to Professor Hardiman's clinic on Thursday and I have your clinic on Wednesday. And I'll say, go to Dublin, we'll juggle the appointments. I keep an eye on the appointments, I book them all just so we can kind of keep the clinic spread out and small. So we'll always work around that. And again, multidisciplinary input. And our goal is to avoid crisis. And I think since we started this clinic, there's been a huge decline in any ED, emergency department admissions. So in conclusion, it is a complex disorder. A person with IMNDA must always be the centre of decision making. Disease-modifying agents are limited, but as Professor Hardiman has shown today, there's a lot of renewed interest, there's a lot of excitement, and there's still ongoing research. And early intervention is vital to manage and alleviate these symptoms. And our MDT and specialist input, I hope, can enhance quality of life and life expectancy. Thank you very much for listening.